Well, Juanita and I thought that this might be a fairly informal discussion, asking each other questions, and get your questions ready as well, because we'll turn to you, because there's absolutely a number of experts in the room.
Absolutely.
But before I begin, as the CEO of Katsanam and more importantly a Narungga woman, I too want to pay my respects to the traditional owners of this land, the Gadigal people of the Eora Nation, and extend that respect to elders past, present, and our future emerging generations, particularly Katsanam and Linman members in the room.
I also, Juanita Sherwood, would like to acknowledge the land we're on today, and the Gadigal peoples, and I'm all nervous, I don't know why.
Sing, Juanita.
Sing. I'm thrilled to be here, and I'm thrilled to be down here looking at all your wonderful faces here. Just can't say thank you enough for coming. But also, I want to acknowledge the land we're on today, and pay my respects to elders past and present and into the future, and particularly a lot of people who came a long way to come here today. And I want to just really acknowledge someone who's been, well, my mum right up the back there, who's here from Alice Springs, and also another very important colleague to me, Tawara Goods, who is from the National Centre for Cultural Competence in Georgetown, Washington. And I just wanted to say hello to everybody else, because it's great to see your faces, and I've missed you all, and it's nice that we can catch up at conferences like this. But I just wanted to say around Tawara, we sat down yesterday as Tawara went through her talk for today, and I remembered the time that I first met Tawara, and I was terrified because I'd taken on and accepted this role at the National Centre for Cultural Competence and didn't know where we were going with this particularly. And we sat down and I just went, oh my goodness, I've learnt so much from you, Tawara, and I just really want to say thank you so much. And we've learnt so much from Sydney University as well. It's been a great opportunity to extend cultural competence beyond the health perspective and to connect with communities. And I mean, we had, this morning we had ACI speaking at this conference, and we've been running cultural competence with ACI. So, I mean, it was a fantastic opportunity. We're out there, and we're just going to get better.
So, first question,
yes.
Juanita knows this is coming. So when did you first hear that term, Juanita, cultural safety? Cultural competence.
First heard it at a Katsan conference before we were Katsanam. And it was in Queensland, and it was Irahapati Ramsden speaking at our Katsan conference. And we sat there and listened to this amazing Maori nurse who talked to us about the importance of cultural safety and the fights that she had. And I can remember a cartoon that she showed us that the New Zealand press had used to portray her, and it was a savage in a hospital bed with bones hanging off their out of their noses and ears, etc. And this is cultural safety, and that's what this poor Irahapati Ramsden was dealing with, pushing cultural safety in New Zealand back in the 80s. Yes, yeah, please.
Okay. So, a bit of a backstory. I'm from Point Pearce Mission in South Australia. So when I went to the Big Smoke to finally do my nursing degree, I was fairly naive, to say the least. And nursing had just introduced this concept of cultural safety. And I was up at Flinders University at the time talking to the head of school. And now she declared herself as a Pākehā woman. And I looked at her and I thought, I wonder where that mob comes from, not knowing that that's what New Zealanders called their white fellas.
Yeah.
And so I was sitting there quite wide-eyed, and at this woman, she had her shoes off. She was walking around a palatial, head of school suite with her arms flinging around in the air and talking about cultural safety. And, well, to put it mildly, I think she could have been speaking a foreign language to me at the time. Like, I couldn't actually understand the concepts or the constructs that she was talking to me about, and let alone racism. To understand racism at that point in my life was literally just a feeling that I encountered. When someone said something to me, I felt shame, or I felt like I wanted to run, hide. So I suppose the gem learning from that was later on I really acknowledged that just because you're a black fella doesn't mean that you have to understand or the terminology around racism, so have that language for that, or that you understand what cultural safety is. I was lucky. She said to me, she gave me a whole heap of readings, and I went away and I read them, and it was just these constant aha moments. And what I described it as was learning about white fellas and their power, their privilege, and where that placed me, and how their attitudes were formed. So it gave me a really interesting, moment that I now get to reflect on and remember. But at the time it was quite funny the way that it all, came to fruition.
And I think there's a big issue around when we do talk about cultural safety, and we've heard this morning that there's a lot of naiveness around what are we talking about. And when we're talking about cultural safety, or we're talking about cultural competence, and I'd like to just say that they basically mean the same. Competence is about a system, but cultural safety is individualised treatment and patient-centred care. And it's just great to see all these new faces coming in. And I think that cultural safety, cultural competence, cultural proficiency, and there's many other names, and I feel often we get lost in being too simplistic about the terminology, and what we really are thinking about is ensuring that, well, I heard it this morning, people have choices and people have control over those choices. So they have a sense of control of what they're having in their health treatment, and they have a sense of being respected in that space. And I guess I learned about cultural safety post my experiences of a lot of institutionalised racism I noticed in healthcare. And I think I particularly was my first research experience, and I think I really tackled naively, I think, but I'm glad I did. I was working in Redfern as a child and family health nurse, and I walked into the community post doing my primary education degree, and so I had nursing and teaching experience, and realised that hearing loss was an issue that really impacted on children's learning abilities. And I was working in schools where I had really high rates of otitis media, which is a middle ear disease, which many children get, and often they're treated with antibiotics very quickly, and they recover. But in our communities, that wasn't happening. People had otitis media for a long time, and it had a big impact on their hearing and ability to learn to listen. If you don't learn to listen between the 0 to 3 years of age group, you're going to have trouble at school. And I raised this within the community health centre that I worked at, New South Wales Health. And I was told, oh, that's not a problem. We don't really worry about that. And I went, no, yes, we do. And that was my first opportunity of working in community, talking to community about, hey, we've got to do something about this. It's not okay. I know this is not okay. I know I've just learned in teaching that, a hearing loss is a problem. And we went to Menzies School of Health Research, of all places, and the Career Centre, and we brought in a researcher who showed us how to do some research. And I don't know whether you remember Jennifer Bush. Jennifer Bush and myself did this community research project where we screened 100 children within the Redfern area. 86% of them had an educational significant hearing loss, really appalling. And with that information, at the time, Linda Burney was the president of the New South Wales Aboriginal Education Consultative Group, part of our community grouping, and she took it up with the Minister for Education, and the Minister for Education said, right, we're going to do something about this. and immediately we had teachers for kids with conductive hearing loss. Before it was just kids who had sensory neural hearing loss, but conductive hearing loss is just as significant, but it had been ignored even by ENTs. A load of ENTs I worked with along this line said, "Oh, why didn't we get this?" And I said, "I don't know. I don't understand why you didn't realise if you can't hear, you can't learn," but, you know, they didn't. And it's, but they were open to listening, and they did hear. Some didn't, of course, but many did hear, and they chose to work with us, which was great, and we did make a difference. And 10 years later, we had ear, nose and throat clinics in all our AMSs across the country. We made a difference because we didn't, we rejected the institutional conceptualisation of, well, that's just the way it's going to be.
That story reminds me of an advertisement that's related to one of our guests in the room, Dr. Chelsea Bond, where the Queensland Education Department put a call out, for Aboriginal. Teachers to go and work in Aboriginal Torres Strait Islander communities, and it was some sort of slogan that basically said she loved working with naughty misfits, with a whole heap of Aboriginal kids around it. Now this is only last year, Chelsea, yeah, and so that's the pervasive messaging that's out there, and so it's easier for our kids to be naughty or to be misfits than it is for them to actually not be having access to good health care.
Absolutely. And I think that's something that we've looked at for a while, and people have been, well, I talk about it a lot, about problematising us in relation to creating, we are a problem because we're not hearing. Well, there is that problem. But flip it. And I guess this is what we've been talking about at the university, is we're the problem, that we don't recognise that we have to provide care to children with hearing loss and to children with vision loss, with speech issues. We need to be providing care to all children, not the 20% that have perfect vision, hearing and speech. And I think that's what we've naively considered, that we are treating everyone the same. And when we treat everyone the same, we actually create minorities, we create issues. But sometimes people haven't been treated the same, and I suspect that's probably our biggest issue in Aboriginal health, is the lack of access to respectful, culturally safe healthcare.
And we do hear that as, health professionals, that cookie cutter approach, or that a health professional will say with pride, I treat everyone the same. But that's, gives us the notion that there's a sameness, and of course that doesn't create equity. And we all, hopefully you've all seen the picture of the kids standing on the blocks, right, trying to look over the fence, and it's about giving people what they need, and really acknowledging that we don't all start from the same place. But going back to your comment before, Juanita, about cultural safety versus cultural competence, and I love this quote, and I'll just acknowledge someone else in the room, Dr. Gregory Phillips, who basically said it in a nutshell, which is, it doesn't really matter what philosophies we're talking about. It's actually that our mob get treated with respect and care, and the best quality care. So at Katzenham we certainly talk about cultural safety, because it does come from Irahapati Ramsden. It is about Indigenous knowledges, and we honour that she was an Indigenous nurse, and so I think there is a bit of a misnomer, I think, with the title of cultural competence, in that there seems to be an epiphany that you can reach and become competent, whereas this is a lifelong journey, right?
Absolutely, and I think from the National Centre's perspective, we've always said that this is a journey, and it's a lifelong journey. You never make it, and it's really critical to tell people that, no matter which community you walk into, there's such diversity. You will never know how to ensure that you work safely. And we often, I guess working in the academy, I've found people are very scared to put their hands up to say, I don't know. It's something that people are fearful of, because this is the space where you're meant to know it all. And in fact, the healthiest thing for you to ever do is to say, I don't know, and I'd like to learn, and I'd like to listen, and I'd like to hear, and how can I, be more helpful in this space? And I think that we often don't appreciate that that's what we need to do as soon as we walk into any space, a health setting, an education setting, and particularly working in communities, our communities and other communities.
So one of the things that happens for us at CATS and Juanita, so we're an organisation of 5 people, and we take care of around 3,000 Aboriginal Torres Strait Islander nurses and midwives, and ensure that they have recruitment and retention issues that they face met.
Can I just say though, you've really improved that number.
Yeah, we're getting there.
Really, it is important.
So probably the larger part of our work is ensuring a culturally safe health system and ensuring that people demonstrate cultural safety, and therefore we have better health outcomes for our people. So if we are 3% of the population and there's the other 97%, why does it sometimes feel like we're doing all the work, do you think?
Well, good question. And yes, we seem to be the people that are pushing the agenda. And I agree. We have been doing, I've been doing this for a long time. I think this has been an agenda that, it's critical. It's if you want good healthcare, you want great education, you want anything, you need to actually appreciate that we have to be working with diversity areas. Firstly, though, I guess what's probably the most critical thing, and I've said this just recently, is that Australia needs to know that it is occupying sovereign lands of Aboriginal people and Torres Strait Islander people, and we have not been given any treaty practices, etc. There is a lot of healing to happen. There's still a lot of recognition of issues. And not that cultural safety is about, you must understand this, but you must appreciate, I guess, the public health agenda, which is, racism causes health inequities. Colonisation and its policies created dramatic health issues. And they've been sustained through colonial policy. They have not ceased. We will be talking about grandmothers against removals who are still, talking about, we've got years and generations of people still being removed, and the numbers are increasing every year. And this is something we do have to recognise is part of a legacy of ongoing knowing what's best for us.
For us, we often talk to non-Indigenous lecturers in this space that we have invested interest. So sometimes when we're talking about cultural safety, it doesn't land in the same place, because it's almost like I'm evangelising people into cultural safety, and I've been accused of that recently in the media. And I think it's, that people don't realise that it's cultural safety, this concept is good for everyone.
Absolutely.
So when you were talking about diversity and joining with diverse groups, absolutely. Yeah.
And I want to say, I've just been recently to Toronto, where First Nation groups say, we want cultural safety. It is an Indigenous focused approach. And really critically, it is important to recognise that we've had a different legacy. And we do need to acknowledge that there is a different type of care recommended. We know that such ghastly health rates are part of not necessarily poor health care, but it's been the lack of access to care. I know there's been so many people who've not been able to have the care that they thought everyone should deserve.
So when you talk about access to healthcare, most people's brains jump to, Central Australia, not geographically not having access to healthcare, but we know that most of our population live here in
Yes,
Western Sydney.
yes.
Okay,
Yeah.
so access to healthcare. I'll just give you an interesting conversation that we often have with nurses and midwives, which is to start to talk about cultural safety, and we say, do you often ask people if they're Aboriginal or Torres Strait Islander? To which some nurses, midwives might reply, not if they don't look it. Okay, so we do anatomy and physiology, thankfully, in nursing and midwifery, and there's nothing in there that prescribes what an Aboriginal person looks like. So therefore, people are drawing upon the sensationalisation of media. And the other thing that they'll often say is, well, I don't want to offend someone. So we begin then to uncover some of the biases the racism that people have been fed, what an Aboriginal person looks like, and that it's actually, I suppose, shameful to be Aboriginal. And we recently went to an APRA conference, and a non-Indigenous student was on a panel with me, and he was saying, I don't know why I ever had to learn cultural safety. And any of you that are in the room that are lecturers, first year, students in your Aboriginal health, culture and history cultural safety course, there's a fair bit of resistance, to say the least, in learning that first topic. And this young man said, well, I'm never going to see an Aboriginal person, so why do I have to learn this stuff? To which, I took a couple of moments to think about it, and I replied to him, well, how do you know when you see an Aboriginal person? What do they look like? And so we unpacked that a little bit, and then I said to him, and do you know how important it is for those Aboriginal students sitting in that classroom to actually hear something of themselves, to actually hear about their own people, not that they're, that we're something in a museum that's a dusty old culture, that we're no longer vibrant and resilient today. So how important that is to learn cultural safety for Aboriginal Torres Strait Islander peoples.
And I think that's critical to why we really want to hit it at university, and why we think it needs to be broadened across the curriculum beyond health is vital, but we've got to be thinking engineering, we've got to be thinking physics, we've got to be thinking every arena. I want every Indigenous student that walks into all universities, not just Sydney, to feel safe enough to be and exist as an Aboriginal person in that classroom, not to be told that I don't need to learn about Aboriginal issues because, they're irrelevant to me. And I think, learning about Aboriginal issues is very relevant to all Australians because we are the first peoples of Australia. And if you don't understand and appreciate and respect that, then you don't respect yourselves. And I think that's probably the most important thing around cultural competence and cultural safety, is not that it just improves the way you work with others. It actually opens your headspace. It actually enables you to consider the world from a point of view that is less about the media's perspectives, it's less about your grandmother's perspective, it's about what you've learnt to learn. And I think that's what we really do target in cultural competence, is unpacking your biases, unpacking how you developed your opinions. Opinions aren't knowledge. How do we build our evidence around what is what we want people to grow and develop knowledge in?
And it's uncomfortable, isn't it?
It is.
There's always that notion between what's cultural awareness versus cultural safety. And I'll say to people, if you didn't get uncomfortable, you weren't in cultural safety training. And if you weren't learning about, things like white privilege, critical race theory, racism, you weren't in cultural safety training.
Yes.
So one last question from me. Have you ever felt culturally unsafe?
Yes. I was saying I had to give you a health experience. I was having surgery, and I was really excited because I'd just handed in my PhD, and we just left it to have the surgery post, And my surgeon came in and said, "Oh, Juanita, have you handed in your PhD?" Because he'd just handed his in 6 months before. And I said, yeah, I'm really thrilled, and I've got it in. And he said, fantastic, and he went into the theatre, and I was meanwhile having a cannula put in my arm to have my anaesthetic to go to sleep. And the anaesthetist said to me, well, what did you do your PhD on? And I stupidly told him. I went, oh, it was on decolonising Aboriginal health research, and doing no harm. And he went, oh my God, Aboriginal people, oh, and he went off on a tirade for 5 minutes as he was stabbing me with the cannula in my arm, and I'm going, I'm meant to be feeling calm and relaxed before I go into this procedure, and this man's attacking me. He was not of, well, he was definitely from another country, and he had this really terrifying ideology of who we were, and I'm going, this is a private hospital, I'm paying to be here, and I'm an Aboriginal person, and you need to look after me. And I was big and brave, and I could do that. So many of our people can't. So many of our people feel, and they leave casualty because they're treated poorly. They just do not get treated well in their settings, and we have to shift that, we have to flip it, and it's not okay to treat people in a way that is so disrespectful. And particularly, he really breached every health story there was, but I did actually take it up with Prince of Wales, and they said I was, yes, exactly. And they said, oh, that was a misunderstanding. Now, this is pretty typical, is it not?
Yeah.
That we have a misunderstanding when people are particularly rude around.
They didn't mean it that way.
No, they didn't mean it that way. No, he didn't really mean he hated every Aboriginal person he'd met, but, he...
He probably had an Aboriginal friend,
He
right?
probably did. Also, he had an auntie who knew someone, yeah. Yes.
Yeah, went to school with someone, love that. So, yeah. I love those moments though, when you're locked and loaded, like when you're in a cab and someone says, where do you work? And I just roll my eyes and I think, here we go.
Yeah.
And he's already locked the door. And so I get told everything about my culture in those moments. Yeah.
And I think that's really it.
Yeah. So shall we talk about the elephant in the room?
Okay.
Yeah, the codes of conduct.
Codes of conduct, yes. I think
So I'll acknowledge the reason why it's in there, the codes of conduct. So Katz and Em did a lot of work in this space, but our actual delegate for that reference group, Sue Anderson, is in the room. And so I'll probably start by saying that it was a very, like all ARPA processes and NMBA, Nursing and Midwifery Board of Australia processes, very long and drawn out. You have the opportunity to do individual submissions, go to workshops, blah, blah, blah. It's almost, consultation to death.
Yes.
There was not one submission that was actually, spoke out against cultural safety in the codes. And I should also mention that, yes, it was in there for the first time, but so was bullying and harassment in there. So we weren't calling people bullies or saying that, nurses harass people, nor were we saying that people are racist. Yes. The codes are about what we want to hold our professions accountable to.
And really, it comes down to, and I guess working in the health field, it is basic occupational health and safety. And it's about ensuring that we do look after people securely. I guess I've had an amazing health experience. I worked at St Vincent's back in 1984 when we discovered we had AIDS in Australia, and that was a massively scary time for everybody, and particularly the health staff at St Vincent's, where 600 people walked out of the hospital too terrified to care for anyone in the hospital. And I was working 6 or 7 wards a shift, and because we just had lost so many health staff, doctors, nurses, health cleaners, everybody just walked away. And it really ignited in me how the few of us that were left in that setting, how important it was to make sure that we made our patients feel that they were valued. These were young men who were dying of a dreadful disease. We just sort of discovered what it was. We only just realised how we had to treat this. And I guess, and what came out of that space was critically some important issues around infection control, things that were about knowledge changes and behaviour changes, which I think, I was thinking that's exactly what we're asking for with cultural safety. It's not something hard. It's about, we do have to change behaviours in this space because we are going to make a difference and we save lives doing this.
I think the other thing with AIDS in that era too was that it was definitely about what was normal, and that was heterosexual peoples, as opposed, to what AIDS was attached to at the time, which was young gay men. So there was certainly a lot of privilege going on and normalisation in that space. So maybe we should turn to the audience.